Occiput has a rhythm, and it's one of the places that's easiest to feel the craniosacral rhythm. And basically, occiput flexes and extends, flexes and extends. So if you want to make the little bones with your hands, this really does help to orient. And then buying a disarticulating skull really helps as well. So flexion and extension. The parietal bones fit underneath the temporal bones, and they move like this: flexion and extension, flexion and extension. But we don't often feel the cranial rhythm at the parietal bones, but that is their motion pattern. Typically, we don't feel the cranial rhythm there. These are the temporal bones. They sit here beside your ears. They contain your inner ear mechanism, and they rotate forward in flexion, backward in extension, forward in flexion, backward in extension. And they're kind of about a 45 degrees, so they're kind of a wobbly. Unless you're you, and yours kind of go like this. Yours don't actually do the same pattern, but they still have the pattern. Okay, these are the cheekbones, or your zygomas. They don't have a rhythm, so we don't worry about them. Then the maxilla, I guess it goes this way, is connected to the pterygoid process of the sphenoid, and its motion is flexion and extension, flexion and extension. Then sphenoid has the vomer on it, and sphenoid rocks forward in flexion, backward in extension, forward in flexion, backward in extension. So when your finger is in the roof of the mouth, you'll feel vomer come down, boink, boink, or it'll be shock or a little vibration feeling. Sometimes it's very obvious, sometimes it's not. The times that it's been super obvious have been almost startling because it's so clear. Then the ethmoid kind of looks like a bat. The ethmoid bone, it contains all of your nasal nerves and all the olfactory bulb, and it hooks onto the front of sphenoid, and it has the same basic rotation as vomer and sphenoid because it's directly connected. Frontal bone has a rhythm, but if you see how concave it is and how much bone goes back and forms the upper shells of the eyes, it's fairly hard to feel the cranial rhythm at the frontal bone. So I don't typically feel it there, but it does have a rhythm. And then the next thing we're going to do is we're going to work on the strain patterns of sphenoid. Now, sphenoid sits like this behind your eyes. The greater wings are here at each side of your eyes. Sphenoid, in flexion and extension, that's its motion. However, it has lesions or dysfunctional patterns. It could be a lateral strain, left or right. It could be a side bending strain, left or right. Or it could be a torsion strain, left or right. A torsion is up towards the top of your head as the patient. Side bending, if the patient's laying on their back, is up towards the ceiling. Okay, because we're going to change. Now we're laying down like this. So we have lateral strain, left and right. Side bending strain, left and right. And torsion strain, left and right, in that orientation. Now, when we worked with Amanda, we were working on the sphenobasilar synchondrosis. The sphenobasilar synchondrosis is the junction between the base of sphenoid and the base of occiput in front of the foramen magnum. Now, you cannot get your fingers in front of foramen magnum or the person's not going to be around. But you can get your fingers to the base of occiput right here. So what I was doing is I had my thumbs on the wings of sphenoid and my fingers on the base of occiput. And I was motion testing to see how they moved. And we found that it moved terrible to the left and pretty smoothly to the right. So we named our lesion for the direction that it moved the easiest and the farthest. Same thing with torsion, side bending, and lateral strain. So let's just play a game. So this is our patient, and we motion test. We bump sphenoid, and it moves to the left nice and smooth. We come back to the neutral, we bump it to the right, it moves nice and smooth. What does that mean?
Lesion.
They don't have a lesion. No, they don't have a lesion
They
because it
don't.
moved equally to each side.
Oh, yeah. Never mind.
Okay? So let's say we bump it to the left and it moves nice and smooth. Come back to the middle, we bump it to the right, it doesn't move at all. Do they have a right or a left lateral strain? The side that moves the furthest and the easiest. And that's kind of hard to get our minds around, but that's cranial work for you. Okay, so now let's say we have a side bending strain. This would be side bending. So as the patient's laying on their back, it's going up towards the ceiling. So if we bump the sphenoid on the right, it moves nice and smooth. We bump it on the left, it doesn't move very well. Which is the lesion? A right side bending strain. Now, if we bump the greater wing of the sphenoid up towards the top of the head, it moves easily to the right and not so well to the left, it would be a right torsion strain. So you treat each one individually. Now there are some cases in the advanced classes where you unwind the whole thing and you do all at once, but it's way too hard to do that before you know what this is like. So we're going to treat each one of them separately and individually. Okay? So we're going to name our lesion for the side that moves the farthest and the easiest. And that is going to be our lesion. So if we can have somebody that wants